Good afternoon, everybody. I am going to talk about FFR, fractional flow reserve. So first thing, why it is done? Because we know that ischemia causes reduced tissue perfusion. Ischemia is caused by coronary artery stenosis. So it causes reduced tissue perfusion. Basically, we know how the ischemia is caused by angiographically. Angiography shows any lesion more than 50 in the left main or more than 70 in the non-left main lesions are significant. So other way of finding what is the significant lesion is by quantitative coronary angiogram by QCA. It gives the percent area stenosis or percent diameter stenosis. So any lesion between 50 to 70 is borderline lesion. We do not know what is the significance of the lesion. So FFR becomes important in this type of lesions. Any lesion more than 70, it needs intervention. Any lesion that is less than 50 does not require any intervention like PCI or CABG. Those lesions between 50 to 70 needs further clarification whether it needs to be intervened or not. In which population it becomes important is those patients who come to the cath lab without any pre-testing for inducible ischemia like treadmill or any stress test, or those patients who come to the cath lab with symptomatic patients but their stress test was negative by stress test, or those patients who have lesions in one vessel but ischemic territory in other areas by echo. So we go into the basic anatomy. The coronary anatomy consists of epicardial conduit vessels. It is more than 0.5 millimeter vessels, and the pre-arterioles and arterioles and the capillaries, which are called the microcirculation. That is more important in maintaining the autoregulation. What is autoregulation means? Whatever type of the stenosis with wide range of perfusion pressures, the autoregulation helps to maintain the coronary flow in spite of wide range of perfusion pressures in the coronaries and blood pressures. So usually the lesions up to 85% of tight stenosis does not cause any reduction in blood flow in resting state. But at the same time, if in hyperemic states, it can cause more than 50% reduction in the flow, it can cause symptoms. So why do you need hyperemia to be induced? What happens when hyperemia is induced? So hyperemia causes maximum vasodilatation. What is maximum vasodilatation means? It abolishes the autoregulation. So we are not able to assess the flow in the coronaries. We are assessing the pressure. So it gives an indirect evidence of the coronary blood flow. So there is a flow indices I am going to now talk about, the pressure indices. So there are various pressure indices. The first and the foremost important is the FFR. So what is FFR? How to calculate FFR? What is FFR? It is going to calculate the pressure difference between the distal to the lesion compared to the blood flow in the normal coronaries. So this is PD, FFR is equal to PD by PA means it is the pressure in the distal part of the coronaries, distal to the stenosis compared to the aortic blood pressure. So what does FFR does is, it calculates the average PD by PA over the entire cardiac cycle. It identifies whether the lesion is physiologically significant. Coronary angiography and QCA tells about the anatomic lesion. The FFR gives about the physiological significance of the lesion. So what is the technique? The technique, it contains, this is the console for FFR and this is the pressure wire. So during FFR, what are the things you have to maintain is hyperemia. There are various agents to induce hyperemia. The most commonly used in the cath lab is adenosine. It acts on the A2 receptors. There are two modes of giving adenosine. One is intravenous continuous infusion at 140 mics per kg per minute. Other is intracoronary bolus. Usually in the RCA we used to give 100 mics, and the LCA we used to give 200 mics, the coronary bolus. So what are the side effects of giving adenosine is it causes chest tightness and dyspnea and conduction abnormalities. These are all very transient and benign. So various other non-hyperemic cases I will tell you later. So this is the case one, Mrs. M, 70-year-old female, long-standing hypertensive, 1 year of diabetes, obese lady. She presented with effort angina for 1 year, and ECG shows sinus rhythm with T inversion to V4 to V6 and normal LV function. So angiogram shows borderline LAD lesion in the mid segment. So after equalization of the pressure, this is the baseline FFR 0.92. After giving intracoronary bolus of adenosine, this is 0.91. So this is this LAD lesion is non-significant. There is no need of intervention. This can be medically managed. So PCI is deferred. There is no need for any intervention. So this is a case 2 where a 63-year-old male, diabetic for 10 years, hypertension for 7 years. He presented with FFR angina for 9 months. ECG shows some STT changes and echo shows inferior MI with EF of 50%. So they show severe OM disease. So by angiographically LAD mid-segment shows borderline LAD disease, and distal RCA shows a very critical RCA disease. He had a old inferior MI. So next, what is the management of the lesion? He had a critical disease of RCA and LCX, borderline disease of LAD. So whether to stent RCA and OM on medical management of LAD, we want to know the significance of mid-LAD lesion. So FFR has been done to the LAD. This is the baseline is 0.89. After hyperemia, it is 0.77. So anything less than 0.8 is significant FFR. So this is technically a severe triple vessel disease. So now the treatment options become we have to revascularize all the 3 vessels, whether it's he has to send for CABG surgery or triple vessel PCA, multi-vessel PCA. So advantages is FFR is considered to be a functional PCA or physiological angioplasty. More than 0.8, no need of any intervention. Less than 0.8 needs to be intervened. And 34% of angiographic stenosis is not accurate. That needs to be confirmed by FFR. The FFR has been shown to reduce deaths, MIs, MACE, and urgent revascularization. It improves the prognosis and optimization of PCI. It is mostly studied and used in stable ischemic heart disease, but now also we are using in the non-infarct related other coronaries, non-culprit vessels in acute ACS situations. Thank you.